This conference will now be recorded.
All right, so we're going to talk about Chapter 4, Communications and Documentation tonight, then followed by Chapter 8. So with the National EMS Education Standard Competencies, we have to apply the fundamental knowledge of the emergency medical service system, safety and well-being of the emergency medical technician, EMT, and medical, legal, ethical issues to the provision of emergency care. So we're going to talk about therapeutic communication and principles of communicating with patients in a manner that achieves a positive relationship. And we'll cover more about that in detail here in a moment. As far as interviewing techniques, I like to call it interrogation, but because we're trying to get information out, but you have to have certain techniques to be able to get the information you're actually looking for from these patients. Adjusting communication strategies for age, stage of development, patients with special needs, and differing cultures. And I can tell you from working in the city as long as I have, I'm not talking about the city of Ossipee, working down south in Massachusetts, there are a lot of different diversities and cultures that we have to work around in people's rights and things like that based on their religions and whatnot. Verbal diffusing strategies, and then obviously family presence issues. We're going to talk about why we need communication and what is needed to call for resources, transfer care of a patient, interacting with the team structure, EMS communication systems, communication with other healthcare professionals, and team communication and dynamics. EMS is not a single sport, it's a team sport. Without having a team, we cannot get the jobs done appropriately. And the more critical the call, the more manpower intensive it becomes, up into like including a cardiac arrest. When you have 2 people, it just doesn't function appropriately when you really need 5, 6, or 7 people to be able to run an efficient cardiac arrest management. So again, team communication is very important. And then documentation at the end of this. You have to record all your patient findings, and then also principles of medical documentation and report writing, which is very important for you guys to do. That leads into your clinical rotations. So every patient contact you have, I'm not going to make you do a run report, but you have to write a narrative describing your patient findings. And I will go over that. And then what I will do is I will email all of you a documentation manual that I made when I'm at work that I designed for new hires at my full-time job. And that way there you guys can see what they have to go through and what we expect out of them for documentation purposes. And I've been doing that for my EMT classes for some time now, giving them a manual of what we expect at my full-time job, because we really take documentation and quality assurance stuff pretty seriously with clinical care. Also medical terminology, which uses foundational anatomical and medical terms and abbreviations in written and oral communication with colleagues and other healthcare professionals. So we start talking about, like, for example, like the abdomen. If I'm talking to a 5-year-old, I'm not going to call it, how does your abdomen feel today? You know, you can change your terminology a little bit to meet the need of the patient that's there. So does your belly hurt? You know, things like that. But medical terminology is very important, especially having conversations with different clinicians. So communication is the transmission of information to another person, whether it be verbal or nonverbal, through body language. Very important to have verbal communication. You're going to be very verbal throughout this entire class. Like I mentioned before, if you start off being shy, you're going to change your personality a lot during the program. We like to say, like, for example, if you're doing your skills testing at the end of the program in the National Registry, we like to say you need to have verbal diarrhea, because you need to actually not stop talking. With that being said, if you do not mention that you were doing something at a testing station, they're looking down at their clipboard, and they don't hear it, they will mark it as incomplete. So you need to talk through what you're doing. You also need to explain to your patients what is going on and what procedures you're going to be performing. Remember, we don't want to just start touching patients at all, right? Because that'd be assault and battery without explaining what we're doing. It also puts the patient more at ease when you explain the process of what you're trying to do for treatments and different procedures. The nonverbal through body language, again, picking up on how the patient feels. You know, if they are wincing and they are in pain, you can pick up on the fact that they are in pain that way, and things like that. Whether or not they make eye contact or not is also another form of nonverbal communication as well. The verbal communication skills are very important for the EMT, which enable you to gather critical information, coordinate with other responders, and interact with other healthcare professionals. Remember, you guys are at the EMT level coming into becoming EMTs. You're going to have advanced EMTs and paramedics coming on board your ambulances if you call for intercepts. You're going to be talking with nursing staff, physicians potentially will walk into the room. Again, like let's say you take a patient to Maine Medical Center. You go into a trauma room, you're going to have 20 people in the room, including residents, physicians, surgeons, nurses, CNAs, and anything and everything will be in that room. And they're going to say, okay, everybody quiet. All right, go with your report. And you're going to basically give a full head to toe assessment report to the entire 20-person staff that is there. So again, communication is very important, understanding the terminology that's out there. Documentation, obviously, is the patient's permanent medical record. And they're not kidding. It stays in the patient permanent medical record in the hospital. Once you complete a run report, it gets transmitted to their fax machines at the hospitals. They take that report. The physician then reviews the report as well of what you did. And then it goes with the patient all the way up to the ICU and into patient discharge, and then they file it. So it actually does become part of the permanent medical record of what you document in EMS. It also demonstrates the appropriate care was delivered. So we look at that to make sure you did your job appropriately based on your clinical standards and your scope of practice. So we look at that. It also helps others in patients' future care as well. Like I mentioned, if they get put on the med-surg unit, whether they get transferred to a different hospital, it's always good to find out what exactly happened prior to arriving at the hospital. It also complete patient records, which guarantee proper transfer of responsibility. They also comply with requirements of the health departments and law enforcement agencies and fulfill your organization's administrative needs as well. Radio and telephone communications are a link between the EMTs to EMS, fire department, and law enforcement. So what you must know is what your system can and cannot do, and how to use your system efficiently and effectively. So I cannot really get into what your systems actually run unless I've worked in those systems before. I can kind of describe the process of how that works. What you guys need to know is wherever you plan on working as an EMT, you need to do on-the-job training to find out exactly how their systems are run. So therapeutic communication uses various communication techniques and strategies, both verbal and nonverbal. Encourages the patients to express how they feel and achieve a positive relationship with each patient. Like I mentioned before in a previous lecture, if somebody is sick, okay, one, remember that is their emergency, not ours. So don't rush to get there, okay? If you get hurt in the process of getting over there, you now put the patient in a higher jeopardy. The second thing is you remember, is that these people are calling in their worst time. That's why they call 911, because something is not going right in their life. Whether it be a psychiatric suicidal type deal, to a trauma, to a true medical patient with like chest pain, shortness of breath. All right? They're trusting that you have the knowledge, skills, and professionalism to walk through that door. They have to engage with you, and you have to engage with them. They have to be able to trust you within the first 30 seconds when you start talking to them. Right? So you got to keep that in mind. Professional, positive relationship with each patient you come in contact with. Let me start going with our question. Remember, showing empathy and sympathy is also very important as an EMS provider. So we look at the Shannon-Weaver communication model. The sender takes a thought, encodes it into a message, and then sends a message to the receiver. So if I'm thinking, then the receiver decodes the message and then sends the feedback back to the sender. So if I say to Joy, so Joy, what did you call EMS for today? She's going to then take that message in. She's going to encode it into her head and say, okay, well, this is why I called EMS. Are you having any chest pain today? And if she'll tell me either yes or no. If she says yes, then I'm going to go a little bit further with the assessment. What does the pain feel like? Is it a sharp pain, dull pain? Is it a pressure? Does it radiate anywhere? On a scale of 0 to 10, how bad is the pain at this point in time, or the pressure? And you can keep going more and more detailed into your assessment. What's happening is I'm now coming up with a thought, I'm encoding it, and then sending it to the receiver.
I'm probably not the best example to use for communication, just saying.
It's okay. We'll get you through it. But the thing is, though, is some people are not the best with communication, and which means I may have to work harder or try different methods to get information out of you to be able to come up with a treatment plan. For example, what happens if you have a patient who has who's autistic? Are you going to be able to communicate with them, or do you have to use different methods to do so? What if a patient is deaf? You know, do you know American Sign Language? I know I don't, but I know how to write down on a whiteboard and have to write back to me. So there are different methods of how we need to do so. And here's just more of a diagram of how this works. So some factors and strategies to consider during communication obviously is age of the patient. If they're a 1-year-old, I don't expect you to have them communicating back and forth. But we can look at different body language and how the patient is actually acting. Are they acting appropriately? Type of clothing that they wear. You know, what are they in for clothing at all? Looking at their different cultures. Education, environment, voice tempo, posture, gender, volume, facial expressions, eye contact. You know, look at all those different things to consider during the communication process. And looking at age, culture, and personal experiences, we're going to shape how our person, definitely shapes how our person communicates. If you had I'm trying to think of a good example. If you had a patient that was involved in a domestic dispute and was assaulted, let's say a female was assaulted by a male, okay? Do you think that the best provider should be a male talking to her at this point in time? Or should we try our best to find a female provider? What do you think?
Female?
Yeah, I'd go with the female. Yeah.
But the thing is,
So.
You're right. Female would be the way to go, but you may not always have a female available. If so, we don't want to put ourselves in a situation where we become overpowering on that female. So get down to the same level. Sit down with them. Don't stand above them and try doing an assessment. Then you're putting yourself above that patient, which then, in turn, makes them feel very uncomfortable. In some cultures, direct eye contact is impolite. In other cultures, it's impolite to look away while speaking. So again, I don't know every culture that's out there, and it's not my job to know every single one that's out there. But if they ask you, hey, can you please not look into my eyes when you talk, right? If that's part of their culture, grant their culture's needs and work with it. Try to move things around. Your tone, pace, and volume of language reflect the mood of the person or perceived importance of the message. You don't want to come in the room just balls to the wall, ready to go, coming in screaming, guns pulled, ready to move, right? Approach patients not at a fast pace. Now, obviously, if they're unconscious, you still got to move a little bit quicker to get in. But if they're conscious, alert, and oriented, you want to have a decent conversation with them. You come in acting like a complete jerk, they're probably not going to give you the information you're looking for. They may tell you just to leave, or they don't want to go with you. If the patient needs to go to the hospital, we got to find our way to make them go. So we have to get down to their level, and we have to have a conversation with them. Try to be positive. If you're having a rough time at home, please don't bring that to work. That can change the attitude and the pace of how things work throughout the day. Cultural imposition, forcing your values onto others, right? If you are a churchgoer, it is not your place in the back of an ambulance to try to convince someone to take God into their lives. It is not our place for that, nor can we start preaching that kind of information, right? Do not force your values on other people. You can talk about past experiences if you'd like to, that's perfectly fine. But forcing your values on other people, patients that are constantly overdosing, please don't force your values onto them. Okay, get them the help that they're looking for. No, that's all we need to do. We don't want to start forcing any other values onto them. Considering your own culture values more important than those of others. So nonverbal communication, body language provides more information than words alone. If you walk in angry, the patient's going to become angry. If you walk in there saying, the body language of, I really don't want to be here because this is our third time today we've given Narcan to this patient, probably isn't the best attitude to walk into. We're still there to do a job. Now, you guys talk amongst each other in the back and in the ambulance way to the call saying, I can't believe we're going back here again. But when you get inside, professional, make it like it's the first time you saw that patient for the day and treat them the same every single time. Your mood will set off a patient in different ways. All right. Facial expressions, body language, eye contact are very powerful communication tools. You got a psych patient that you're dealing with. One of the worst things you want to do is not look directly at them and look like you're shy around them, because they'll read off that, they'll feed off that, and try to take advantage of the situation to put you in a bad situation. You want to make sure you still have control, but it has to be professional while doing it. When we get into behavioral emergencies, we'll talk more about how to handle that kind of stuff. Help people understand the message being sent, okay? Even if you have to use hand signals to kind of help with that. Does your chest hurt? You point to your own chest. Does your chest hurt? Does your stomach hurt? Kind of get down to their level. If you have a pediatric patient, we'll teach you guys how to do what they call a toe-to-head assessment, because kids don't like people touching their faces and heads up front. It's always good to start down low. So we'll talk about that later on too. I know that's more of the verbal communication stuff, but non-verbal. Body language, eye contact, things like that. So when treating a potentially hostile patient, be aware of your own body language, right? Stay calm and try to diffuse the situation. Assess the scene for safety. If the scene is not safe, you do not go in, okay? Hang back. Do not assume an aggressive posture. If you walk in there ready to fight, there's probably going to be a fight, right? Make good eye contact, but do not stare at them, okay? Patients that have these types of situations, for hostile patients, do not like being stared at, but still make eye contact. Speak calm, confident, and slow. All right, if you walk in there as a brand new EMT and you're like, I don't know what I'm doing, and they can read that, they can feed off of it. Never threaten a patient either verbally or physically. Do not tell them that you're going to put the patient down. Do not give them that option to find a way to come back at you to make them hurt you because you made a threat of some way, shape, or form. And as tempting as it may be sometimes, we still have to put that aside. You may get called to a domestic patient or domestic violence call where the male hit the female with an object doing significant damage, but she retaliated back and hurt him, let's say stabbed him, right? I understand that we're probably all thinking, well, why the hell would we help this guy, right? We still have a duty to act. We still have to treat them regardless, okay? So again, don't use judgment. Make sure you follow your scope of practice and don't find yourself in negligence because of it. So physical factors on literal noise, sounds in the environment, lighting, distance, physical obstacles may also affect your communication. Cultural norms often dictate the amount of space or proximity between people when communicating. There are still people that are out there that are very paranoid when it comes to COVID-19 and still want their 6 feet distance, okay? I come in contact with that already, and it happens quite often. I say, can you please stand back a little bit farther unless you need to come closer? Gestures, body movements, attitude towards the patient are critically important. Go into the room, be polite, ask them how they are doing, okay? Why did you call EMS today? It's different how you say that. You walk in and go, why did you call again today, right? That's going to change a lot of things, right? Because you're coming in there saying, well, why are we here? Well, I don't want to be here. Or Hi, my name is Kevin. I'm here at the ambulance. What did you call EMS for today? The way your tone is sets literally the tone of how things are probably going to go on that ambulance transport and or the patient care. Asking questions is a fundamental aspect of pre-hospital care. We want to ask open-ended questions which require some level of detail whenever possible. Use whenever possible. Example, what seems to be bothering you? If you are asking a patient question, especially more towards the elderly when things are a little bit slower in life. If I said to, let's say if Sean's an elderly patient today, Sean, you're going to be old today. You're going to be 80 years old.
Sounds good to me.
Right? And I said to you, hey, Sean, how are you feeling today? And you gave me an answer about, I'm feeling pretty good. Well, do you have any chest pain, shortness of breath, dizziness, nausea, vomiting, headache, diarrhea?
Well,
how are you going to answer
that way?
What was that?
Are you asking if that's how I would answer?
No, if I said that to you, I'm the paramedic coming in, having a conversation with you, and I say, do you have any chest pain, shortness of breath, dizziness, nausea, vomiting, headache, blurry vision, diarrhea? That's what I said to you.
Not all at once.
Right, but if I said that to you all at once, how would you be able to answer me? What if you said yes?
I mean, I definitely have chest pain today. I've had too many energy drinks.
Good board. But if you said yes to that, right? Okay, which one did you say yes to? Was it the shortness of breath? Was it the chest pain, the diarrhea? I don't know. So ask them open-ended questions, but again, you got to be slow about it. Sean, do you have any chest pain today? You tell me yes. Are you having any shortness of breath?
No.
Have you had any nausea or vomiting?
No.
Okay. Now we're getting more into the questions, and he has a chance to come back and give me an answer. And yes, Deb, I love your comment. 2 all beef patties, special sauce and lettuce. So again, it's how you ask the questions is how you're going to get the answers back. All right. And don't ask them questions that are completely like off base from what you're trying to get to with your assessment. Right. We want to ask them questions that get to the answer of how we're going to come up with a diagnosis and treatment. All right. If they're having chest pain, I'm not asking, well, does your big toe hurt? It doesn't make any sense. It doesn't go along with the questioning that we're asking. But if I'm going to tailor it towards a chest pain assessment or a respiratory assessment, it's a little bit different based on the question. We're going to talk about sample and OPQRST later on. These are going to be some acronyms you're going to need to know. Closed-ended questions can be answered in very short responses. Those would be, are you having trouble breathing? If the patients cannot provide long answers, then use the closed-ended questions. Open-ended, though, like before, it's always good to ask more questions and have to describe what's really going on, why they called. That helps a lot more with the open-ended questions with psychiatric patients or suicidal patients to kind of find out what's going on, if they had a plan, if they were homicidal, suicidal, what's been going on in your life that caused you to feel this way, there's things like that. But your normal sample and OPQRST stuff would be more of your closed-ended questions you're going to be asking. Like, when did it start? How bad is the pain? Is it sharp or dull? Severity of the pain? Things like that. So some other communication tools would be facilitation, even just silence, listening to your patient. If your patient's talking to you, remain silent and listen, because listening is one of the most important things we can do as an EMS provider. Because how else are we going to come up with a diagnosis if we can't listen to what's wrong with the patient? Having some empathy and sympathy for the patients as well. Make sure you get clarification. If you don't understand something, don't play it off like you do. Can you clarify that? Confrontation. Do not be confrontational with a patient. Please don't. If the intoxicated patient is being a royal pain in the butt, don't become confrontational, okay? Try to find a way to de-escalate that situation. So because I know some of your backgrounds, I'm sure, Sean, that you've dealt with a lot of confrontation working in the jail. You've had to de-escalate a lot of situations, I'm sure, as well.
Every day.
Yep. Explanation. Can you please explain that to me? Or maybe they want an explanation on what you're doing. All right. You're going to be assisting a patient with nitroglycerin because that is part of your job as an EMT. And they go, well, the doctor really never told me anything about nitroglycerin. So can you explain to me why I'm taking this? What does it do? All right. They told me if my chest hurts, just take it. Right. So that's not a good enough explanation. Some interviewing techniques, as you can see here with the female attendant in the back. You notice how her arm is on his shoulder and her hand is on his hand? That shows compassion, okay? But avoid touching the torso, the chest, and the face, okay? There's nothing wrong with the shoulder. There's nothing wrong with the hand. Please do not grabbing patients' chests. Very inappropriate, all right? Don't start rubbing their legs. Very inappropriate. I've noticed with more of the, I've seen providers say, call people hun, sweetie. We cannot be doing that. Okay, we don't call patients sweetie. We don't call patients hun. We call them by their name. All right, Mr., Mrs. Unless they've given you permission to call them by their first name. It's always a Mr. Smith, Mrs. Smith, whatever it may be. Some things to avoid: providing false assurance or reassurance. Never tell a patient everything is going to be okay. Because if 10 minutes after you say that, they die or they get very sick, you told me everything was going to be okay, right? Watch out for that reassuring. What you can say is we're doing the best we can to help you get better. That's not a lie. We are doing the best we can. Give unsolicited advice. Giving unsolicited advice. Asking leading or biased questions. Talking too much. Please do not be the one that talks over every patient. If they're having a conversation with you, do not interrupt them. Using why questions. Well, why did you do this? Why did you do that? Because it kind of puts blame on somebody. Using authoritative language. Now, it says to avoid that technique. Sometimes you have to be authoritative when you start dealing with more of the psychiatric or ETOH patients. But again, be careful how much authority you start pulling because it can really piss somebody off. Then speaking in professional jargon. You start talking about, oh, well, your gastrocnemius muscle hurts. Why don't you just say the calf muscle? Is your calf bothering you today? Is the back of the leg bothering you? You know, things like that. Does your thigh hurt? You know, you can use things like that, but how does your femur feel? Well, some people don't even know what the femur even is. So professional jargon is great when you're having conversations with other professional employees, physicians, nursing staff, people that you work with. But with the patient, you want to make sure you tone that down and get to the level of the patient is. Remember, they may not have any medical knowledge, or maybe they do. You'd be surprised how many patients we come in contact with that used to be nurses that are retired. They just don't tell you. It's always good to know more about your patients and talk to them when you have conversations. The presence of family, friends, and bystanders. Friends and family may be valuable during the patient interview process. However, can also be a big hindrance as well. So allow the patient to answer even if well-meaning family members attempt to answer for the individual. All right? So what was going on today? And the family member goes, well, they started having chest pain earlier. I got it, but I need to hear this from the patient. Not only are we trying to get information from the patient, we're also checking mental status. And if the family member is answering all the questions for them or hinting them, you say, what month is it? And the family member goes, well, you know what month it is. It's June. Oh, well, yeah, it's June. Well, okay, well, they didn't know what that was initially. So don't be afraid to ask others to step aside for a moment if you need to gather information. You got a female, let's say, I'm going to put this out there. You got a 14-year-old female with abdominal pain. What are you guys thinking at this point in time? What do you guys think?
Could be pregnant and afraid to tell her parents.
Exactly. Do you think that a 14-year-old is going to say in front of their mother and father that she's been sexually active? That she's not using birth control, she's been sexually active? Right, or it could be independent, depending on where it's located. We'll talk more about that, Deb, when we get into abdominal pain as well. But again, if they're sexually active in childbearing years and they have unexplained abdominal pain, one of the most common things that would be for a female is an ectopic pregnancy. Right? Something to think about. And it's going to be very tough for that female 14-year-old to start saying that she's been sexually active with her 18-year-old boyfriend that she has in front of her parents. That could be a problem. So maybe having the parents go to a different room with your partner EMT, maybe they can talk to the parents aside and maybe have the patient talk with the other provider in a separate room. And you might be able to get more information. So there's different things that you can utilize. The golden rules: keep eye contact at all times. You lose eye contact with your patient, then something could happen. Provide your name and use the patient's proper name. My name is Kevin. What is your name? Well, my name is George Smith. You can say, well, do you mind me calling you George? Sure. They may say, call me Mr. Smith. Depends on what you want to use. Tell the patient the truth. Please do not ever, ever, ever lie to a patient, because then if you do and they catch you lying, you've lost all credibility. And the next time you go there, because they're a frequent flyer, and you go there back all the time, you've lost that credibility because you've lied to the patient. Be careful what you say about the patient to others. And be aware of your body language as well. Speak slowly, clearly, distinctly. Allow the patient to understand what you are saying. If you think you are speaking too fast, slow down. The patient says, hey, can you slow down? Then slow down your responses. Give the patient some time to answer. Yes, Deb, you had to ask a question.
I need to go back to the asking people. Can you hear me?
Yep.
Yeah. Okay, so I need to go back to asking people to step outside if the patient is a minor. And the reason being is that in my other life, I'm dealing with a young sexual abuse victim that the abuse has been going on for several years, couple years. And they don't want to talk in front of their father. And their father is using basically a male minister for counseling to try to figure out their behavior, but they don't want to talk to the minister either. Nobody has been aware of this sexual abuse for several years. And it did come out to me, and I had to talk to the person about talking to my chief, because he is a mandatory responder and I'm not. So, a mandatory reporter and I'm not. And he's held to HIPAA and I'm not at this point. So that person agreed, but the father is saying like he wants to be in there. He doesn't want her talking to anybody, counselors, chief, anybody alone. And as his parent, as her parent, he's asserting that right. So at what point do we just stop? I mean, I don't understand. That's a fine line for me because I'm dealing with it now, that this patient continues to want to talk to only me, and I'm not any of these things. But I don't understand, like, if we say, if this patient needs to talk to somebody privately about what's going on, but the parent is asserting their parental right to be present to hear it, how do we ask that happens? Do you understand what I'm asking you?
Yeah, I do. And one of the things you can do is get the patient to the ambulance for transport and then ask them questions in the back of the ambulance. Because one of the things that we're not allowed to do, and you can also enforce this, is have family ride in the back of the ambulance.
Okay. So just stop that assessment right there and move it into the back of the ambulance.
Absolutely. Because you have that right to deny patients, family members, get in the back of an ambulance due to space. Because you have to be able to move, and if you don't have enough seatbelts or space in the back, then they can't ride out back with you. They can sit in the front of the ambulance. That's perfectly fine. Just close the window between the front and back, then have a conversation with the patient.
Okay, thank you.
Yeah,
Yeah,
if you suspect something, just pass it along to the nursing staff. There's ways of getting to the hospital to remove a parent from a child. There are ways this stuff can happen. It's a little
Okay.
more complicated.
Because
Social-
I'm dealing with that now, all of that commentary that we just had, it's nerve wracking for me, because if it's a minor child and you're trying to remove everybody from the room, but the parent is asserting their parental rights, like that is a good way to do it, is to move that all into the ambulance. Thank you. That's a good answer. Thank you.
You're welcome. Somebody else have a question?
I was just going to say, I believe in New Hampshire, any adult is a mandated reporter if you suspect abuse. I don't think you need to have a.
Yeah, I'm not sure how that works in New Hampshire. I know that me being a provider, I'm a mandated reporter for everything. So, but yeah, we have to report stuff as we see it. So we want to make sure we act and speak in a calm, confident manner. If you come into a room and you are cocky with the patient, it may not fare well for you, especially if it's someone who's intoxicated. But if you're confident and do your job and be professional, speak in a calm, cool, collective manner, you're more apt to get farther with that patient than you are. So we want to communicate with older people. Identify yourself, and as you can see him sitting next to her, right? Get down to their level, have a conversation, present yourself as a competent, confident, and caring person. They are scared because they called 911, okay? Do not assume that an older patient is senile or confused. I've made that mistake before, not the senile or confused, but I always speak louder for elderly. And they just, sometimes they said to me, "Why are you yelling?" Oh, I thought maybe you'd have a hard time hearing me. I apologize. All right. So speak normal, calm. If they say, "Can you speak a little louder?" Then they give you permission to talk a little bit louder to them. Right. Sometimes with elderly, they might call 911 and they say, "Oh, well, I don't feel well." Really, they're perfectly fine. They just need someone to talk to. So just going there and just having a conversation with them, they may sign a patient refusal form after because really all they wanted was someone to help them out. They're lonely. You may encounter communicating with older patients. You may encounter hostility, irritability, and some confusion. Do not assume that this is normal behavior, right? If they are hostile, irritable, or confused, you want to get more of a medical history. Okay, could they have dementia, Alzheimer's, or are they having a diabetic issue? Do they have the potential of having a stroke, like a head bleed? That can cause irritability. That can cause confusion. Strokes can cause confusion. You know, things like that. So you want to do a more in-depth assessment to find out what is really going on. Approach an older patient slowly and calmly. Do not rush at them. Okay, it can scare them. And allow plenty of time for the patient to respond to your questions. They are going to be a little bit slower to respond, so give them that time. Hey, Deb, can you mute your phone?
Oh, yeah. It's my phone?
Yeah. Thank you. All right. Watch for signs of confusion, anxiety, or impaired hearing or vision. Look for it. Usually you can see when they're confused, they're having a hard time answering questions. Or if you see repetitive movements of their hands, they're tapping, or they're anxious, or impaired hearing, right? They have hearing aids in, or you see them sitting on the nightstand. Ask them if you need help getting them put in, or vision issues. The patient should feel confident that you are in charge, that everything possible is being done for him or her. Remember how I mentioned earlier? They're calling you into their worst time. They expect you to know everything and have all the answers. That's why they call. Be professional, be confident, and do your job. And also be patient. Be very patient with older patients because they don't move as fast as we do when we're younger. All right? Yes. So Tondra said, tapping fingers could also be an essential tremor as well. That is correct. Remember that older patients sometimes often do not feel much pain, okay? So they could be having a heart attack and all they could have is upper epigastric pain, and that's it. Because their body has changed so much over time, they build up some neuropathy and they can't feel certain things, right? So they may have atypical chest pain. A lot of times female will have just upper epigastric pain or may have some shoulder pain but no chest pain, and they could be having the big heart attack. Right? Some people are just different than others. So you still want to make sure you do your full assessment. You may not be fully aware of important changes in their body systems. They may not tell you. You must be especially vigilant for objective changes, okay? And look for stuff. Patients that are unresponsive with a fever and with low blood pressure could be a septic patient. And you roll them over and you notice that they have bed sores on their bottoms, on their backside. That's probably causing that infection. Or if they self-cath at home, and it could have a potential for UTI. So asking those questions can give you more answers to be able to come up with a definitive treatment plan. When possible, give patients time to pack a few personal items before leaving for the hospital. I'm not telling you to give them 45 minutes, all right, but let them pack some stuff. Locate hearing aids, glasses, dentures before departing. Older patients are often worried about the safety of their home, valuable items, and their pets. All right. So when you go into a home, please make sure you close the door behind you because they may be afraid that their cat or dog might get out. Make sure that their homes are locked. I'd say reassure them. Assure them that you will lock the doors. Okay. Let them know. I tell them the truth. I'm going to lock the doors as we're walking out. Do you have your keys with you? Make sure you ask that question. The last thing they want is to be brought home by a taxi cab or an ambulance service and their keys are locked inside their apartment. Before you go, unless they're critical and you got to rush out to get to the hospital, if they're stable, make sure they got all their stuff that they need to get back into their home and assure them that the doors are locked. All right. Any questions so far before we start getting into kids?
Yeah, Kevin, I have a quick question.
Yeah, come on.
So you get called to a house where maybe the patient is unconscious, they see him on a camera or something, gets called in through a third party. As a first responder, you see a dog sitting in the house with a person. What are you gonna do to know if the dog is like potentially could bite you or whatever? Could
Right,
be
make
vicious.
sure that have law enforcement come in with you so they can secure the dog.
Okay.
Or if you need to contact animal control to come in as well.
Okay.
Again, you don't want to put yourself in a situation where the dog is going to attack you.
Right. You know, we just assume the dog is friendly.
Stress to get in. Let's say the dog's in the living room and the patient's in the bedroom. Can you go through a bedroom window to get into the patient and be able to get the patient out that way, or find some way to secure the dog? Are there anybody else around that can help you secure the dog in some other way? Usually the animal control officers are pretty good at getting this stuff to happen, or they may have methods of doing so. But again, protect yourself. All right, so communicating with children. Sorry. I like that, Tondra. Keep the bones in your pocket. Dog bones. Yep. Thanks, Deb. All right, so communicating with kids. Whole different world. Fear is the most obvious and severe in children. Okay, so emergency situations are definitely frightening for them. Children may be frightened by your uniform, the ambulance, or crowd of people gathered around them. We talked about kid assessments a little bit. Yes. Sorry, text box a little bit here. Bribery works. It does. Let's go into another room. Absolutely. So children may be frightened by uniform, crowd of people, ambulance. When we go in, talk to the parents as you're getting your assessment with the kid as well. one of the biggest things to ask a parent is this normal for you? Is this normal for the child? If they say no, he's not acting normal, that's a problem, right? Because now we know the parent said there's a problem. There's something not acting right. All right. So then at that point, you want to start assessing the child. When we assess children, we always want to start at the feet first. That way they can gain the confidence as you move yourself up the body to the head. Let the child keep a favorite toy, doll, or security blanket. It helps them. And if possible, the family member or friend nearby. If practical, let the parent or guardian hold the child during the evaluation or treatment. They can hold them, it's perfectly fine, as long as you're not suspecting any type of abuse. Now, if there is abuse in the home, you cannot go up to the father or mother and say, are you abusing your kid? That is not our place, right? We are to treat the patient we are called for, get them to the hospital, and then we can do mandatory reporting afterwards, right? But it's not our place to accuse anybody of anything. Be honest. Children easily see through lies or deception, so be honest with them. Tell them what's going on. Tell the child ahead of time if something will hurt, right? If you're going to check out blood glucose on a kid, let them know that this is going to sting on your finger a little bit, but it does go away, and it does, all right? So let them know what you're going to do before you do it. Respect the child's modesty. Please do not strip down a kid naked, all right? Unless you absolutely have to, like an unconscious trauma patient thrown from a vehicle. That we understand. But if they say they have belly pain, there's no reason to take off their pants and underwear, right? So keep their modesty intact. Speak in a professional, friendly way. As you can see, getting down to the kid's level. You notice how he has his hand on his foot. We're starting from foot to head contact, so what they call toe to head assessment. You want to get down, man, maintain eye contact and get to the same level and have a conversation with them. Let them tell you what's going on. All right. Communicating with hearing impaired patients. Most have normal intelligence and are not embarrassed by their disability. Position yourself so the patient can see your lips. A lot of them can lip read. Hearing aids. Be careful that they are not lost during an accident. They may be forgotten by the patient if the patient is confused. And you also want to ask the family about the use of hearing aids. So if you're going to an elderly, or someone else should say elderly, anybody with hearing impaired, ask them, do they have hearing aids? And if so, can we put them in so we can have a conversation? Again, if you don't know American Sign Language, one of the best things you can do is have a pad and a piece of paper and write down questions. So like we mentioned here, some different steps to effectively communicate. Obviously, if the patient can read lips, face the patient, and speak slowly and distinctly and never shout, right? These are the patients you want to ask those closed-ended questions to. And also one question at a time so they have a chance to respond back. So listen carefully, ask short questions, give short answers. Learn simple sign language for sick, as you can see from the left side of the screen to the right side of the screen. All right, so sick is belly to head, hurt, as you can see in the middle, pointing, 2 fingers, and help is fist in the palm. Ask the patient if he or she can see at all. Visually impaired patients are not necessarily completely blind. Expect the patient to have normal intelligence, okay? Do not treat them like anything different. Treat them like everybody is the same. Explain everything that you are doing as you are doing it. I'm going to put this stethoscope on your back and listen to your lungs. I'm going to palpate your chest. I'm going to palpate or push on your stomach. I'm going to put this blood pressure cuff on your arm. It's going to get tight as I squeeze it. This allows me to get an accurate blood pressure. Let them know what's going to happen, okay? Talk your way through it. Stay in physical contact with the patient as you begin your care. If the patient can walk to the ambulance, place his or her hand on your arm. Now, walking patients. If your patient has shortness of breath, chest pain, altered mental status, dizziness, right? Do not walk these patients. Put them on a stair chair and bring them out that way. Any more exertion on a patient like this can actually cause more damage, right? It can cause more stress on the body. You want to take mobility aids such as a cane with you to the hospital, right? Wheelchairs, not so much. We have to find a way to secure stuff inside the back of the ambulance. It's dangerous to put wheelchairs in an ambulance. But cane, walkers, things like that, yeah, you can take those with you. They fold up. And it also gives them more of a sense of security for it. If they have guide dogs, which are easily identified by a special harness, if possible, transport the dog with the patient. Yes, we can do that, right? We don't take animals to vets. That's not what we transport. We transport people to hospitals, right? However, in Massachusetts, many of you decided to go work down there with your National Registry certification. Massachusetts just passed a state law that if you have a police service dog that is injured in the line of duty, you can transport that dog to an emergency veterinarian by ambulance. They passed that law there. I don't know what we're going to do for the back of the ambulance for them because we're not trained to treat animals, but we can at least bring them to a hospital. But if you have a service dog, those can go in the back of the ambulance with you to the hospital. Service dogs are allowed to go inside hospitals. They go into the rooms. But if you cannot transport the dog for some reason, then you want to arrange for care for that dog somehow. So not so much up here as it is more in the cities, more in Massachusetts and whatnot, that I've worked in other bigger cities. Or if you work up in like northern Maine, northern New Hampshire, when you got French Canadian coming over that speak French Canadian, and you can't understand them, non-English speaking patients. So you have to find a way to obtain a medical history. Apps on your phone, like Google Translate or Apple Translate, help out tremendously. Find out the patient speaks some English. Even if it's broken English, you can try to get something. Point out body parts. If you have a family member that can interpret in the back of the ambulance with you, that's okay to have them come in the back because they're an interpreter. And let the hospital know they're going to need an interpreter for that patient. They have ability to do that. When I worked over at Huggins Hospital, we had an iPad that we could bring into the patient's room that had the ability to have someone get online with us to interpret pretty much any different language. It took a little bit longer to find somebody, but they came on board. That was a great tool. Yeah, so some ambulances, Deb put down Lebanon ambulance has animal oxygen and tools purchased by donation by residents. Yes, so some ambulances do carry like dog oxygen masks or pet oxygen masks. So there are the ability to do so, and we can do that for on a scene. Give a dog oxygen, where we are allowed to provide that type of care. However, we cannot transport them. And when you become ALS, no, we're not doing IVs on them or anything else. Okay, it's just providing oxygen and simple care, wrapping a wound or something, that's perfectly fine. Consider learning some common phrases in another language that is used in your area, right? I don't expect you guys to learn Italian if you're not working in a primarily Italian area. Now, if you're working for Boston EMS and your coverage area was the north end, then yeah, absolutely. You know, Spanish, whatever. Let's try to learn simple phrases and simple questions to ask. Yes, so thanks, Josh. They do have interpretation apps on your phone as well. So Apple and Google both have a Translate app that you can download. I think the Apple Translate is part of the package now as soon as you purchase your phone. And you can utilize that and speak into it. Then what will happen is it will translate it for you and put it in speaker, which is really nice. And remember to request a translator at the hospital, but they need to know. If it's something patient that's critical, let them know ahead of time that you have a patient that speaks Russian or German. Let them know. So when communicating with other healthcare professionals, your reporting responsibilities do not end when you arrive at the hospital. You still need to talk with the nursing staff to give a report to pass on, and or the physician will come in the room and you have to have a conversation with the physician on what's going on. So give an oral report to the staff members who has at least the same level of your training. So like I mentioned before, as an EMT coming in, you cannot give a report to a CNA or LNA, okay? They are considered a lower level than you are. EMTs can give reports to nurses, paramedics in the emergency department, and any kind of physician, PAs, or nurse practitioners, things like that. And when you're giving an oral report, you want to make sure that you have opening information, name, chief complaint, illness. Then you go into your detailed information, which is not provided over the radio report that you give. Radio reports going to the hospital in the back of an ambulance gives them a heads up what's coming in, anything critical, in the last set of vitals, and maybe any kind of treatments that may have been done. Depending on where you're working and what city you're working out of, some hospitals don't even want a radio report in. Like if you transport a patient to Mass General Hospital, unless they're critical, they don't even care. You'll go to triage. I'll take care of it when you get in. Any important history not already provided as well. And any kind of treatment that you've done after you've given your report. The patient's response to any treatments given en route. So if I gave a patient nitro, did the patient's pain get better or worse? Last set of vitals. Not every set of vital signs you took during transport, but the last set. Nursing students and interns, no, you cannot give them to them at all because they are there as an intern or a student, so they cannot take a report. They can listen in, but it has to be someone who works for the hospital that holds a title, certification title, credential. So written communication and documentation. So PCRs, patient care reports, also known as pre-hospital care report, is a legal document that records all care from dispatch to hospital's arrival. There are two types, written and electronic. Written reports we really don't see anymore. We have what they call drop sheets now. You fill out some information, leave it at the hospital so they have something to go by, but then you still have to go back to your station and complete a full run report. That's going to be your electronic ones. Pretty much nationally, they've gone electronic run reporting. And for me to say what reports you guys are going to utilize, it's hard because there's so many different programs that are out there. Where I work, we have what they call Easy PCR, which is a program that was developed by the company. The state of New Hampshire, if you don't have your own specific one, then they have something called NH-Tempsys. Maine is using something called MEFRS. Massachusetts, they have Image Trend as well. Vermont uses something called Siren, which is Image Trend's program. So again, every state has something a little bit different in what they report. The PCR serves as 6 functions: continuity of care, legal documentation, education, that's more of your CQI process, administrative information for billing, essential research records. So we report something called NEMSIS. NEMSIS is a national EMS reporting system. So all of our data goes to the state, which then goes to the national level, which helps with reporting and helps with protocol development and things like that. Then evaluation and continuous quality improvement, that's your CQI process, quality assurance, quality improvement. That's what bases education as well. Information collected on the PCR be your chief complaint, level of consciousness or mental status, vital signs, your initial assessment, and patient demographics. Your assessment will also go fully head to toe as well. And like I said, I'll send that out to you guys tonight on what I utilize where I work full-time when I give it to new hires coming in. Administrative information gathered from a PCR includes the time that the incident was reported to the time it was notified, on scene, transporting at the hospital, and then patient care transfer. Those are more of your administrative times as well. Like I said, there's different types of forms. Most of the stuff that you're seeing now is going to be all Dropbox with a couple fill in the blanks, and then your narrative at the end. The narrative section of the PCR, elements of your narrative, what you're going to type down. There are different methods utilized, and we'll cover those here in a moment. But you'll have to include in the narrative whether you use SOAP, SOAPier, charts, D-charts, story format, all those different methods. They all have to include this: the time of events, assessment findings, EMS care, changes in patient after treatment, observation at the scene, final patient disposition, refusal of care, and then staff person who continued the care, who you gave report to. So to include significant negative findings as well as importance of observations about the scene. Do not make any judgments about the patient's condition. Okay, so do not put your thought process behind it. Avoid radio codes and only use standard abbreviations. Remember that the report itself is considered a confidential document. Reporting errors, if you leave something out of it or record it incorrectly, please do not try to cover it up. Do an addendum to the report, okay? Do an addendum. Falsification results in poor patient care and may result in suspension and or legal action or termination from where you work. If you discover an error as you are writing your report, draw a single horizontal line through it, initial it, then write the correct information next to it. Do not try to erase or cover anything up. If you have a refusal of care, the common source of lawsuits is refusals. It seems like you need to document more on patient refusals than you do with a patient who is not, who is being transported. Have the patient sign a refusal of care form, and have the family member, police officer, or bystander also sign as a witness. And then you want to make sure you complete the PCR. So I think you said, Condors, what if the patient is alone? So if the patient's alone, you want to be careful what you sign. So if a family member is not there, a police officer is not there, your partner can sign as a witness, make that as a last-ditch effort. Is that where you were going with that, Tandra? Okay. So you can have your partner sign, but it has to be last-ditch effort. Reason being is, let's say you're going to a reported lift assist at 3 o'clock in the morning, and you guys want to get out of there and go back to bed. The patient actually does have some form of injury, okay? But you talk the patient out of it, and you have them sign a refusal, and you go home, and the patient's dead in 3 hours, right? That's why it's dangerous to have your partner sign, so they can utilize that. I would refrain that, having PD come in if you don't need it. You can have, like I said, you can have your partner sign. The best ones to have sign are people that are not licensed. So if a firefighter is there, have them sign it, because they don't hold an EMS license. It makes life a little bit easier. And it's also not your partner. So try to have someone who is not your partner to sign. And
I've had your guys at Action ask me a ton of times to sign, so I can see that.
Yep. Yep. We try to avoid having our partners sign because of that case where you guys talked about it going to the call, making that determination this is going to happen. So they try to avoid that from happening. So special reporting situations, depending on local requirements, gunshot wounds have to be reported, dog bites. In New Hampshire, dog bites have to be reported to the local PD. Infectious disease, for some infectious diseases, have to go through infection control. Any kind of suspected or physical or sexual abuse, MCIs also have to be reported as well. Communication systems and equipment. So radio and telephone communications link you and your team with other members of the EMS, fire, and law enforcement communities. Help the entire team work together more effectively and provide an important layer of safety and protection. Yes, dog bites that were reported to animal control for Maine as well. Provide an important layer of safety and protection. So when we're looking at giving radio reports, they're done over the radio and they are recorded lines. If you contact medical control for a consultation, it's done over a recorded line. So that way there everything was used and can be kept in case there's ever an issue with what happened with the patient, something not being reported and things like that. So it's always done effectively. Also radio communications as well with our dispatch centers and everything else. Yeah, Sean, go ahead. You're good.
My question with the dog bite. So is that something that you report like after the call is completely over and your report's written, you just pass it up to a supervisor to report, or is that something that like you call dispatch and let PD know like pretty quickly?
Yeah, you just call dispatch, let PD know, hey, we had a dog bite here. Here's the patient not patient information, but you know where the dog was located. We did that at Huggins Hospital all the time. Every time we had a dog bite come in, even if it came in non by ambulance, we just notified Wolfboro PD and they came in and took the statement. They just have to track
Okay.
it. Yeah.
And what information are you permitted to give to the PD? Because obviously, like, you still have to protect the patient's information. So, like, what would that report look like if you don't mind going into a little detail on that?
Yeah. So when you're not actually doing a physical report to PD, you're letting them know that you have a dog bite, and they send law enforcement over and they do their investigation on their own.
So they talk to the patient.
Oh yeah, they come. Excuse me, they come to the hospital or they go back to the house and have a conversation. We don't get involved in that. We just let them know there was a dog bite at that residence.
Okay, thank you.
Yep, and then just obviously document in your narrative as well. You know, reported to nursing staff on the dog bite, and let's say like Wolfboro PD notified. So or whoever.
Okay, very good.
Yep.
Thank you.
So a base station radio is a base station contains a transmitter and a receiver in a fixed place. So a base radio, you'll see more of these like in dispatch centers, where the two-way radio consistent of a transmitter and a receiver. So mobile and portable radios. The mobile radios are radios that are found mounted in the ambulance, and portable is ones you carry on you. With that being said, base radios have more power output than a mobile radio does, but a mobile radio has more power output than a portable radio does. It's all based upon the power pushing out for transmit. I am not by any means a radio guy, and if there's somebody that's in this class that knows a lot more about radios than I do, feel free to speak up. But with that being said, there are places where mobile radios can reach out to hit repeaters to get back to to be able to talk with dispatch or medical control than your portables can hit. So it depends on where you're located. Mountains also play a big factor into this as well. So it's all based upon when can your antenna get to the highest point where the repeater is located to be able to transmit out to a dispatch center of some or whatnot. But you use to communicate with dispatch primarily. Very true. Another thing to add to this as well is they do have pagers that are out there, and those are not two-way radios. All they do is they activate a tone, and you can receive information, but you can't transmit. Portable radios are handheld devices. So again, they can be enough to fit in the palm of my hand to big bricks that can be a weapon for a psych patient. They're essential at a scene of an MCI. We need to have good communication. And also helpful when away from the ambulance to communicate with dispatch, another unit, or medical control. We don't do a ton of medical control over radios, not out here. Most of it's all done through cell phone. We call it recorded line with that. So repeater-based systems, which is what most of our systems are out here, are all repeater-based. Receives messages and signals on one frequency. They automatically retransmit them on a second frequency. So you transmit in on one, it goes to a repeating system, then transmits off their second frequency to back to that base radio, which allows two mobile or portable units that cannot reach each other directly to communicate using a greater power and antenna. So repeating systems usually put like a higher mountains or top of the tallest building in a city, where that way there you can hit that and transmit over. Some cities actually run repeater systems right on their trucks because they can't hit certain parts of the buildings are too tall. They have repeaters built antennas on their trucks or maybe command units, things like that as well. And a lot of times you'll find certain areas where they call it dead zones. The people that are in the fire service probably know what I'm talking about, where you can't reach out in a mobile radio or anything else because it's just there's no way to hit the repeating system. So as you can see here, you have dispatch, and you can see their antenna in the background there. They transmit out, it goes to a repeater, which then transmits it to the ambulance, fire apparatus, whatever it may be. And then it goes same thing back when they transmit back over. The only difference is that the mobile radios and portables are not as powerful as the base radio pushing out. So if you have someone that has a mic keyed or somebody that's talking, dispatch can actually override you because they have much more power going out. So digital equipment. Digital signals are the part of EMS communications. With that, telemetry allows electronic signals to be converted into code and audible signals. Signals that can be transmitted by radio, telephone to a receiver with a decoder at the hospital. Data from cardiac monitors can also be transmitted by a Bluetooth-enabled mobile device. So where I work, we have that set up. We have something called Cradle Points. They're like $1,500 internet systems in every one of our ambulances. With that being said, we can transmit our EKGs, our 12-lead EKGs, to the hospital through Bluetooth technology and or internet technology and send it to a fax machine. So the physicians over there can actually review our EKGs before we get there. So we have that capability.
Kevin, I've got a question on that one.
Yeah.
On sending the EKGs, how does it know which hospital to go to? Because like I know Action transports to Memorial and Huggins. So like if you want to transmit that, how can you decide which hospital it goes to? Is there like an option for that?
There is. So inside each cardiac monitor that we have, there is when you go to transmit it, it has a list of different hospitals. Now for us, we have all the Mass hospitals in there and all the New Hampshire hospitals that we transport to, but it's one program. We just got to decipher through them all. So if we want to transmit to Wentworth Douglas, we just select Wentworth Douglas, go to transmit it, and then it goes based on that phone number that's attached into the system, and it faxes it to their fax machine.
Okay.
Yeah, so they have to make sure they select the right one. Now, if they put down Springfield Hospital by accident, then Springfield, Massachusetts Hospital is going to get a 12 lead from ostomy. So they got to make sure they choose the right one.
All right, good enough. Thank you.
Cellular satellite telephones. So everybody has their own phones now. I don't see a lot of phones in ambulances anymore. But EMTs often communicate receiving facilities by cell phone, simply low power portable devices, all they are. Satellite phones, sat phones are another option, but again, those are very expensive. Not many services carry those. And can be easily overheard on scanners as well. So you got to be careful when information is being given out. If somebody wants to find something to listen to, they can. All the hospital frequencies, when you give information over the radio, when you call in a report to the hospital, those are all on scanners. You can get the frequencies and listen in. That's why we got to be careful. No names over the radios. If you're going to give a name, we have to call by cell phone. Another thing to mention with that as well. So an important factor with this, if you have a very critical patient, okay, and you're going to like a critical access hospital, Sanford Medical Center, Biddeford Hospital, Huggins, Memorial, Laconia, whatever, wherever you're going to be working. If you have a critical patient, give them a heads up. Let them know that you're coming in with a critical patient. They'll call more later. If you have a stroke patient, call by cell phone. Give them their name and date of birth so they can do a pre-registration. So that way you can bypass ER and go right to the CAT scan and get a CT done right away. Things like that. So it helps with pre-registration so they can get everything in the system. So that way the patient can be assigned to certain areas of the hospital where they need to go. Other equipment ambulances usually have an external public address system. EMS systems may use a variety of two-way radio hardware. Simplex is a push-to-talk release to listen. A duplex is a simultaneous talk-listen, and a multiplex system utilizes two or more different frequencies. And then they also have dedicated medical channels. So up here, Maine, New Hampshire, you find the hospital you're transmitting to, and you just call them. So I'll say Huggins Hospital from Action Ambulance 3. Go ahead, just coming in 10-minute ETA with a 65-year-old male complaining of chest pain, right? Very simple, direct to the hospital. You go down to Massachusetts on, let's say, the east coast side of Mass, the east side of Mass, North Shore, South Shore, whatever it may be, they have something called CMed. And CMed is a whole different world. You call one answering point, but then they contact the hospital for you. You go to a different channel and they connect you guys together. So again, every state's a little bit different how they do things. You just got to learn. You got to learn your systems. But Northeast CMed is out of Lawrence General Hospital. Boston CMed is out of Mass General. So again, Boston CMed covers 30 different hospitals down there. 20 different hospitals. And they just basically direct your call via radio. Trunking systems allow for the latest technology to allow greater traffic. As an interoperable communication system, which allows all the agencies involved to share valuable information in real time. New Hampshire got a massive grant many, many years ago for a statewide interoperability, which bought radios for every service in the entire state. Portables, everything. With that, they also said that the first, let's say it has 7 banks in a radio, which have different channels in them. The first 3 banks you can do whatever you want with. After that, 4 through 8 is dedicated to state interoperability. So that way there, if you have a massive incident, they tell you to go to bank 4, channel 6, and that's going to be the communications for that town. So the state of New Hampshire did a very good job with interoperability. Maine has not done that. Massachusetts does not have that I know of either. Mobile data terminals inside ambulances, what they call MDTs. This is becoming more popular for the bigger city stuff. And I've also seen it a lot utilized for transfer companies as well. They receive data directly from dispatch and allow for expanded communication capabilities like maps and GPS systems built in. They can actually send you from the dispatch center to your ambulance, patient demographics, medical histories, whatever they want. They can do all this kind of stuff. So you can look it all up before you get there. Bigger cities use that also to sign en route on scene. So that way there's no radio traffic. It's all done by pushing a button. So yeah, there's other methods that are out there called MDTs, or mobile data terminals, that are inside the fronts of the ambulances now. As far as communications go, The Federal Communication Commission, FCC, regulates all radio operations in the United States and allocates specific radio frequencies, licenses all call signs, establishes license standards and operating specifications. They monitor radio operations. They listen to everything that they choose to do so, and limitations for transmitter output as well. So there are radios out there like ham radios that you can program frequencies into. Ham radios are actually illegal to be utilizing for public safety because of the power output that comes out with it. Some people, though, however, do use them, but they're not supposed to. All right, so responding to the scene, the dispatcher receives it and determines the relative importance of the 911 call. What they'll do is what they call emergency medical dispatching, EMD, where they ask a series of questions which gives them a certain determinant level. Alpha, Bravo, Charlie, Delta, Echo, Omega. Omega being the lowest possible, like kind of like a transfer. Alpha being the lowest injury type or medical. The Echo level being the most critical. And they assign the most appropriate unit to respond. Then they select this. The dispatcher then selects, dispatches, and directs the appropriate EMS unit, coordinates with other public safety services, provides emergency medical instructions, which is EMD, to the caller on the phone. So if you call 911 in New Hampshire, you get Concord. Concord then sends you over to the appropriate dispatch center. New Hampshire has one public safety answering point, which is called a PSAP. Maine has quite a few. So for the people that work in the Sanford area, Sanford dispatches a PSAP. They're the public safety answering point, and they're the ones that do EMD coding. So when you hear calls about Alpha, Bravo, Charlie, Delta, Echo, those are the ones you're seeing. So EMTs report any problems that took place during a run to the dispatcher, and also inform the dispatcher upon arrival at the scene. So again, communication back and forth. Take what dispatch has to say to you with importance, okay? They can give you a lot of good information, but the only information they're giving you, though, keep in mind, from the patient, when the patient tells them over the phone, right? I've gone to calls before where the patient were dispatched for chest pain, and they told me, well, we just told it was chest pain. We thought we'd get an ambulance here faster. So, Deb, to kind of go on that. So, not a lot of places, bigger cities utilize still alarms versus box alarms. So, a still alarm is kind of like an engine company that responds out, or an ambulance is a still. A box alarm is usually utilized for a bigger response. If that makes any sense. If we want, like, to say, for Sanford, for example, if they put out a box alarm, then they're going to get Springvale plus Central, versus a still alarm, which could be just an ambulance, or depending on EMD coding, an engine in an ambulance. Does that make sense? It's really based upon how many units need to respond. That's all. So communicating with medical control in hospitals. The principal reason for radio communication is facility communication between you and medical control. Medical control may be located at the receiving hospital, at another facility, or sometimes even another city or state. So the areas we work in, our medical control is going to be the hospital that we're transporting to. If you're working for Action Ambulance out of Massachusetts, our medical control is the Whidden Hospital. So again, it's all based upon what system you're working in and what medical control would be for you. So Deb, a box alarm would be like, I'm trying to think for Sanford would be like all apparatus. Building would be like a box alarm. Or they may put out
On my phone, I unmuted my phone too, Kev. But what I've been hearing lately is every call that comes out of Sanford now, no matter which town it's for, like they're saying transmitting a still alarm or transmitting a box alarm. And I've actually heard somebody once say desk alarm, which I didn't know what that meant. But everything that I'm hearing now is box alarm or still alarm, and then they go on to say it's either a medical or a fire, and then they go on to give like the code determinants. And all of that I'm fine with, but I'm still not sure. Box alarm is more if there's more of a response needed, like mutual aid or like to follow a run.
So, like for example, like I'll use Portland as an example. If they have a medical call, they'll probably count as a still, which means they send out an ambulance only or an ambulance with a ladder or an engine, whatever it may be. If they put out a box alarm, that's usually for a building fire, which gets everybody coming in from the city.
Yeah, well, that would make sense. But when we're talking like, let's just pull a name out of a hat and say Acton, and they're saying a box alarm for a medical call, and I'm not quite sure what that is.
Right. So they should. It's very complicated because some people don't use the terminology like they're supposed to use it. If that makes any sense.
Yeah.
So they could call box alarms as like a water rescue being a water rescue box. That means they're going to get water rescue specific equipment.
And it could be from like Shapley or any of the responding towns.
Well,
that it's
the box alarm is different than a first alarm.
Okay.
So this is more fire talk. But if they put out a first alarm assignment, then they get the outside communities. The box alarms, still alarms are that specific department only on apparatus response.
Okay. Yeah, and I'm fine with it on fire. I understand it on fire. Where I'm not getting it is when it's coming through on med calls. Like, I mean, it would make sense on a water rescue because different towns have different pieces of equipment and different certifications and stuff. So I'd be even fine with hearing a box alarm on a water rescue call. But when it's just a basic med call, I'm not really. I get stuck on it. I'm not really. And I probably should just ignore it, but I can't because it's me. But
we can talk more about this offline too, if you want.
Okay, yeah, that would work. I get confused with it, so yeah, if you don't mind reaching out later.
Yeah, absolutely. All right.
Thanks.
So communicating with medical control, consulting with medical control serves several purposes. One, it notifies the hospital of an incoming patient. So we do not call med control to give a radio patch. We call the nursing staff that's there. Medical control for us up here is for consultation if we need to go above and beyond to ask more information about the patient conditions and how we're going to treat them. Provides an opportunity to request advice, as you can see, consultation, and advises the hospital of a special situation too as well. If you're coming in with a patient that if you're coming in with a patient that needs decontamination, they need to know before you even start transporting, because there's a whole entire system that has to be set up for decon outdoors. They have tents they have to set up, and maintenance has to get involved, and teams have to come in. So if you respond to a hazmat situation, they need to know early so they can start setting stuff up for it. We'll talk about that towards the end of the program. So when giving a patient report, follow the established format and include your unit identification number, level of service. So this is Lebanon Ambulance 1 coming in at the medic level with a 10-minute ETA of a 65-year-old patient complaining of chest pain. Patient stated the chest pain started 2 hours ago, sudden onset, about a 10-on-10, crushing pain in the chest. I've got an IV established, given nitro aspirin with minor relief. EKG showed this, vital signs are this, and we're about 10 minutes out. Any other comments or concerns? And they'll let you know, yeah, either a yes or no. Yeah, we have concerns with this, or can you give me this information, or we're all set, go to room number 4 on arrival, or room assignment on arrival. I'll let you know when they get there. The other role of medical control is either offline indirect or online direct. So your offline medical control is going to be your protocol books. Okay. So your protocol books are offline med control because you have a medical physician that oversees the entire state, and they sign off saying, Each level can do this as standing orders, right? Then you have your direct medical control, your online. That's when you call them on the phone and have a conversation. So at the EMT level, you're going to need permission to help administer nitroglycerin. You can't just do it on your own, right? So that's one of the medications you have to call med control with. So administer certain treatments, determine the transport destination for patients. So you got a trauma patient and you want to bypass go to a trauma center, medical control, give them a call. If you want to stop treatment or not transport a patient, medical control can be consulted for that. But again, you also have standing orders. In most area, medical control is provided by the physicians working at the receiving hospital, which is a link to medical control is vital to maintain a high quality of care. Use them. If you have a patient that's a high-risk patient refusal, patient is unresponsive, and they wake up and don't want to go to the hospital, contact medical control. Have a consultation. Let the physician talk to the patient on your cell phone. Put them on speakerphone, let them have a conversation. Maybe the physician can convince that patient to go. Many variations have developed across the country on how medical control works. Again, learn your system that you work in. When calling, there are numbers of ways to contact them. The dispatcher monitors and assigns appropriate clear medical control channels, which we do not do. Centralized medical emergency dispatch resource coordination centers, which we don't do around here. Ours are just picking up the phone, calling a phone number, and you talk to the hospital. The physician bases his or her instructions on the information that the EMT provides. Remember, they can't see the patient. This is why it's important to transmit EKGs and things like that, so they can kind of get a better picture. But you have to paint the picture. Don't use codes, okay? Because physicians have no idea what 10 codes mean. They have no idea. Plain English, right? Have a conversation with them. Let them know what's going on. Paint the picture. They don't have all day to talk to you. They also have patients they have to attend to. So get to the point. Ask them what you're looking for, or have a consultation saying, I'm not sure what to do next with this. What are your thoughts? Repeat the orders back word for word, then receive confirmation. So if you ask them permission to give nitroglycerin, I'm going to use that as an example. You call in, you give the patient report to them, looking for permission to give 0.4 milligrams of nitroglycerin sublingual, may repeat 3 times as long as systolic blood pressure stays above 120. He says, yeah, go ahead with that order. All right, so permission to give this. What is your name? Doctor tells you his name, and you document that in your narrative. This is the physician that gave you the orders to give up to 3 nitro. If you're an EMT and a doctor says to you, I want you to sedate that patient and intubate them, okay? They may not know what EMTs do. Some physicians have no idea what we do pre-hospitally, right? If they tell you to intubate, you can't say, well, med control told me to do it. No. I mean, you follow your scope of practice. Let them know over the phone, we cannot do that. We're at the EMT level. It is not within our scope. They may say, let's start a paramedic and have them start that way. Okay, we'll make that call. All right? But don't put yourself in a situation. Some other information regarding special situations. You may initiate communication with hospitals to advise them of an extraordinary call or situation. For example, hazmat, rescues in progress, or MCIs. They have to be notified of this stuff early so they can start planning. If you have an MCI with 30 patients, I'll tell you right now, these small critical access hospitals cannot handle 30 patients. You're going to have to decipher what they can take. We'll get into that more in MCI management. Keep several points in mind. The earlier the notification, the better. Stroke, STEMI, all these different types of alerts, it's good for them to know ahead of time because they have a lot of things they need to set up in the hospital. And identify any special needs and how many number of patients. And then you should follow your system's plan on top of that. Like any other EMS equipment, radio equipment must be serviced. The radio is your lifeline, to make sure it's serviced. Remember that. Other public safety agencies, who protects you as law enforcement or medical control. At the beginning of your shift, check the radio equipment. It should be part of your truck check that you do when you first come in. Backup plans that must be followed if something fails. It may include standing orders. So learn what your services have for SOPs and SOGs in regard to equipment failure. All right, we're going to take a 15-minute break after this review, and then we're going to start in the next one. We kind of went over an hour. So when healthcare providers force their cultural values onto their patients because they believe their values are better, they are displaying what? All right, D. Number 2, when communicating with an older patient, you should do
A.
perfect. A it is. When caring for a 5-year-old boy with respiratory distress, you should
D. D.
Yeah, seeing a lot of D's. D it is. Number 4, which of the following pieces of the patient information is least pertinent when giving a verbal report to a nurse or physician at the hospital?
A.
I'm saying A's and B's. Remember, all this stuff on here is still important information, but they're looking for the least importance.
E.
Answer is family medical history is not essential in the emergency treatment of a patient. That's textbook National Registry. Family history, absolutely, by the way, street talking now is very important. Because if someone that's 40 years old is having chest pain and their father died at 40 years old from a heart attack, that's important information. So again, textbook, least important. Real world, very important information to find out. All right, number 5. Which of the following statements about the patient care report is true?
D.
Which one is true? All right, I'm ready to put down C. C is the correct answer. A device that receives low frequency signal and then transmit at a relatively higher frequency is called
D.
all right. And the answer is C. When treating a potentially hostile patient, you should try to diffuse the situation by doing what?
C.
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 C. Speak calmly, confident, and slowly. Number 8. All of the following are functions of the emergency medical dispatcher except
E.
very good. D. Awesome. Number 9. So after receiving an order from medical control over the radio, the EMT should do what?
E.
Perfect. D. Repeat the order. Exactly. Number 10. When requesting medical direction for a patient who was involved in a major car accident, the EMT should avoid what?
Using radio codes?
Yep. So the answer is A. Yeah. Radio codes are bad. Excellent. All right. So it's 7:50. I'll see you guys back at 8:05. You have 15 minutes since we kind of missed our last break.
Thank you.
Yep.
This conference will now be recorded.
All right. So we're going to do chapter 8, lifting and moving patients. So we need to follow the National EMS Education Standard Competencies for EMS operations. with that knowledge of operational roles, responsibilities to ensure patient, public, and personal safety. So in this course, in the course of a call, you will have to move patients, to provide emergency medical care and transport. It happens. Every patient, we're going to be moving patients by a stair chair, by a stretcher. We have other methods out there called hover jacks, hover mats, bariatric stretchers, winches, ramps. There's all these different methods, backboards, longboards, KEDs. All these different things are out there for helping us move and lift patients to different areas that we need to move them to. To move patients without injury, you need to learn the proper techniques of how to lift. One of the most common injuries we see in the field is going to be back injuries. You've got to take care of yourself. Knowledge of proper body mechanics, also power grip, and a power grip is important. So what you see here is a wheeled ambulance stretcher, also called an ambulance stretcher or gurney. Most commonly used device. This one here is actually a power system, power cot. So it's run by DeWalt batteries. It goes up and down. It's got wider wings for wider patients. It allows you to do Trendelenburg, lifting the feet up, to bending at the knees. It goes up and down. These are expensive stretchers. Not all services have these. They also have stretchers that from Stryker, or this one here. They also have another company called Furno that is very commonly used. But Stryker also has something called a power load system, where there's absolutely zero lifting involved at all. So when you do your ride time, part of loading and unloading patients will be part of your job. So you'll be able to utilize stretchers. And then when you get hired someplace, it's also part of your new hire orientation as well, at least for when you work for me over in the New Hampshire division where I work. If you were to come work there, we put you through stretcher training anyways. Then you sign off on skill objectives. The wheeled ambulance stretcher weighs between 40 to 145 pounds, generally not taken up or down stairs where patients must be carried for any significant distance. Yeah, and you also need to make sure you have good pathways as well, getting in and out, because these things do not go very well over deep snow. They don't go over well over mud. Strikers have better tires on them, wheels, I should say, than utilizing the Furnos, which are a little bit thinner wheels, make you get stuck a little bit more. So again, know the equipment that you have. Moving the patient, they move the patient by rolling using a stretcher or other wheeled devices. It's preferred when the situation allows and helps prevent injuries from carrying. So we can wheel somebody out by a stair chair or a stretcher, way easier. They also have different, we'll talk about stair chairs in a moment. There are a number of different models available. You need to be familiarized and you need to be certified on the ones that you work with at your service. Before going on a call, familiarize specific features of the stretcher and your ambulance does carry. I'm not going to cover all these in the lecture because there's so many different ones that are out there that they can be utilized. General features, however, there's a head end and a foot end. There's a strong metal frame to which all the other parts are attached. They're hinged at the center to allow elevation of the head and back, and guardrails to prevent the patient from rolling out from side to side. You also have a series of buckles as well that allow the patient to be secured. The mattress on there has to be fluid resistant, no holes. If there's holes in it, then it's marked out of service until repaired. And the undercarriage frame allows adjustment to any height. So again, it's not any height. If it's a manual stretcher, not power related, there's different heights you can go to, but it's not just up and down like a power stretcher does through hydraulics, where you can stop at any height. It's a little bit different. These are backboards, so long, flat, and made of rigid rectangular material, mostly plastic. Wooden ones are back in the day. We don't see many wooden ones out there anymore. Usually they're all plastic now. Used to carry and immobilize patients with suspected spinal injury or trauma. These are not utilized in New Hampshire and Maine anymore, or even Massachusetts for spinal immobilization now. They're used as a carrying device to get them to the stretcher, and they're taken off. So they use what they call scoop stretchers now to get patients out from homes, so it's easily removed from underneath the patient. Commonly used for patients found lying down. used to move patients from out of awkward places. They usually run between 6 and 7 feet long, and the whole service handles in a place to secure straps. You also got to be careful because those are finger pinching points as well. When you move a patient, take care that the injury does not occur to you, to your team, or to the patient. Make sure you have enough manpower there to move a patient effectively. Patient lifting and moving are technical skills that require repeated training and practice on how to lift patients up. Again, like I said before, one of the most common injuries you run into is going to be a back injury, usually lower back. Many EMTs are injured lifting and moving patients, and using proper body mechanics and maintaining physical fitness greatly reduces the chance of an injury. Lifting with your legs, not your back. Okay, squatting down, lifting up. And we'll, like I said, when we do more practical scenario stuff, like on 27th, we get you ready for your clinical rotations. We'll be going over stretcher operations more in detail. So anatomy review, obviously you have your spinal column, the shoulder girdle, pelvis, legs. We will go more in depth on musculoskeletal injuries on the bones of the body. When lifting position, shoulder girdle should be aligned over the pelvis. Hands should be held close to the legs, and the force then generally goes essentially straight down the spinal column, which then very little strain occurs. Okay, so again, we're going to go over this stuff in person anyways, and how to do proper lifting. As you can see, this guy here, everything's all in line for a lift. If for some reason the patient is too heavy, then you can 4-point it, putting people on 4 corners and lifting that way as well to reduce the strain on the back. You may also injure your back if you lift while leaning forward, or if you lift with your back straight but bent significantly forward at the hips. So you've got to have the proper techniques. And don't be afraid to call for a lift assist, because that is one of the most important things to have manpower to lift. And you can always tone the fire departments if you're responding as an EMS service only, or call for an extra engine company if you're working for a city department to get more manpower there for lifting. There's nothing wrong with that, because you don't want to have anybody go home injured. The cost for someone being injured, workers' comp wise, is unbelievable. Not only that, you only get 60% of your paycheck. So you're going to lose money. You're going to be out of work for a while. You have to go through physical therapy. You have to be cleared to come back to work. On top of that, the service then has to pay out overtime to cover your shifts, which then also puts the hurt on the budgets as well. It's not worth it. So this right here is not a correct way to lift. You need to crouch down and lift. Right now, there's people lifting with their backs. They're going to pop out their vertebrae. Let me tell you, they're going to be in a lot of pain if for some reason something slips. Pulling muscles, this stuff puts you out of commission for a while. Legs should be spread apart about 15 inches, shoulder width. Place the feet in the center of gravity, so the center of gravity is balanced. With your back held upright, bring your upper body down by bending at the legs. Grasp the patient and or the stretcher when lifting. Lift the patient by rising your upper body and arms, straightening your legs until standing. Keep the weight close to your body. That way there you don't have any kind of movement going front, back, side to side. And keep your arms the same distance apart. Any kind of tweaking can throw your back off and pull a muscle or pop out a vertebrae or something like that as well. On the power grip, it gets maximum force from the hands. So palms up, hands about 10 inches apart, and all fingers at the same angle. Fully support handle on a curved palm, as you can see here. What that patient is currently on is called a scoop stretcher. We'll talk about those in a little bit. So when directly lifting a patient, tightly grip the patient in a place and manner that will ensure that you will not lose your grasp on the patient. The last thing you want to do is have someone strapped to a board and you drop them. They have no control. They can't put their hands out. They can't stop themselves from falling. And you don't want that, just ask for a lawsuit by dropping a patient. So let's not drop patients. Some principles in safe reaching and pulling are called the body drag. For those of you that are firefighters, you should be used to this body drag scenario already. Those who are not, then this will be something that's new. The same body mechanics and principles apply to moving, lifting, and carrying a patient. Keep your back locked by tightening your abdominal muscles, kneel down, extend your arms no more than 15 to 20 inches in front of you, and alternate between pulling the patient by flexing your arms and repositioning yourself, like this. Belt underneath the arms and drag them to a safe place. This is very important when you got patients in tight spots to get them out to an open area to actually work. The days of working cardiac arrest next to toilets, which we'll have to call commode codes, we don't do those anymore. We got to get them out to open areas so we can have plenty of resources to be able to work on a patient. Move them. To drag a patient across the bed, you want to kneel on the bed and to avoid reaching beyond the recommended distance. Drag the patient to within 15 to 20 inches. Complete the drag while standing at the side of the bed and use the sheet or blanket under the patient rather than dragging the patient on his or her clothing. All right? If you got to move the patient onto your stretcher with their sheets and take their sheets with you to the hospital, look at it back. In the hospital, transfer the patient from the stretcher to the bed using a body drag. Usually it's a side lateral move. The stretcher should be the same height as the bed or slightly higher than the bed. That allows momentum to go down. And you and your partner should kneel on the bed and drag in increments. Usually you have enough manpower in the hospital to kind of help you. When doing a log roll, this is a patient with a spinal injury, to move them, or if they're unconscious, you need to lift. This is why I like using scoop stretchers instead. Someone's going to hold C-spine. At the count of 3 for the person in the head, you're going to roll. On 3, roll the patient up, slide the board underneath them, and then have them roll back down onto the board. You want to keep the kneel as close as you can to the patient's side as possible. Keep your back straight and lean solely from the hips. Roll the patient without stopping until the patient is resting on his or her side and braced against your thighs. Pull towards you, which allows your legs to prevent the patient rolling over completely. So roll them into you. Whenever possible, use a device that can be rolled. When a wheeled device is not available, make sure you understand and follow guidelines for carrying a patient on a stretcher. So the patient's estimated weight before lifting, adults often weigh 120 to 220 pounds. I don't know where they got that from. 2 EMTs should be able to safely lift this patient's weight, in theory. If you think you need more help, try to use 4 providers to lift when possible. It's more stability. It requires less strength. Makes it a lot easier on the backs and won't wear you out as far. You go to an unconscious patient on the 2nd floor of a tight staircase going down, it's going to be difficult getting them up and down these stairs. So they're going to have to be secured to the board appropriately. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. Know the weight limitations of the equipment and how to handle patients who exceed weight limitations. Where I work, we have something called a hover jack system, which you put a patient into and you can slide them, which is pretty interesting stuff. And one of your practical days, I'll go down to the other base and bring it over so you guys can take a look at it. It's pretty neat. Lifting and carrying a patient on a backboard or stretcher, where more of the patient's weight rests on the head half of the device than the foot half. So put your stronger of the 2 providers at the head, who can carry more weight. The diamond carry and the one-handed carry use 1 EMT at the head and the foot, and the other one's on each side of the patient. More of your diamond. That makes life a lot easier when carrying a patient, as you can see here. Try to avoid walking backwards if possible. That just gives you more of a chance of tripping and falling over. Use 4 providers, 1 provider at each corner of the stretcher to provide an even lift. The last thing you want is uneven lift. That can throw people's backs off. When rolling a wheeled ambulance stretcher, make sure that is in the fully elevated position. Your partner should also control the head end and assist you by pushing his or her arms held with the elbows bent. So this is a stair chair. This is a Furno there's Striker, like I said, there's all different types that are out there. These ones here are very nice because they have what they call a track system on the back, which helps patients get downstairs, from upstairs, like going down a staircase, and it adds like a self-braking system as you're going down. So technically, you can hold on to it with one hand and have like no strain at all. I'm not saying do that. You still want to keep two hands secured to the device, upper and lower. But it helps get your conscious patient down a flight of stairs. They have chest pain, shortness of breath, abdominal pain, and they can't walk. There are a lot of different scenarios where this is utilized. Moving a patient on the stairs of the stair chair, a backboard should be used instead for a patient, it says, with a stretcher. Please do not bring stretchers up and down stairs, okay? It is like a two-step into a house, it's different. But if you're going up 5, 6, 7 steps, it's not worth it. You're going to hurt yourself doing it. We don't bring stretchers to the second floor unless there's an elevator going to the second floor. These patients got to be removed by a scoop stretcher, backboards, stair chairs, things like that. But a backboard should be used instead for patients that are unresponsive, need to have be in a supine position, or need to be immobilized. We're going to carry the patient on the backboard down to the prepared stretcher. Place the strongest EMTs at the head and foot, or the taller person at the foot end. Place both the backboard and the patient on the stretcher. Secure both the stretcher with the additional straps. In New Hampshire and Maine, and this is National Registry, New Hampshire and Maine, the backboards need to be removed from the patient if possible. Okay, we don't leave them on boards anymore. Loading a wheel stretcher into the ambulance, where as we come out, we're going to put the head end towards the ambulance, make sure it's hooked in place. We're on the rail system, we're in the power load system. Ensure the frame is held firmly between two hands so it does not tip. The newer models are self-loading, allowing you to push the stretcher into the ambulance, so it's a little bit different. Other models need to be lowered and lifted to the height of the floor or the ambulance, depending on which one it is. Again, be familiar with the ambulance that you have and the systems you're running. And then the clamps in the ambulance hold the stretcher in place, whether it be like a horn system, a track system, or the power load hook in as well. Team actions must be coordinated. So you have to have somebody that's going to be in charge. At the count of 3, we're going to lift. 1, 2, 3, lift. If everybody lifts on their own pace at their own time, somebody's going to get hurt. So we got to be very careful with that. It indicates where each team member should be. It rapidly describes the sequence of steps performing before lifting. The person in charge, make the call. What are you going to do? How are we going to do this? How are we going to get them out? Team leader. Preparatory commands are used. The team leader says, all ready to stop, to get the team's attention. The team leader says stop in a louder voice, and then you stop. Countdowns are also used. A count of 3. 1, 2, 3, lift. Right? So everybody's prepared. Carefully plan ahead. Right? Don't just start loading patients and start taking them out of homes. Find the path of least resistance to get out, and find a safe way to get out. If you can wheel a stretcher on a grass area to the back porch, which is level to the house, instead of going down 18 steps down to the ground in the front, let's go to the back and come down the grass with a 4-pointing going down, make it a lot easier, right? Emergency moves are used when there's potential for danger, like fire, explosives, hazmat, critical patients that are unresponsive. We got motor vehicle accidents. We use what they call an emergency move. So this is used when you cannot properly assess the patient or provide immediate care because of the patient's location or position. If they're unresponsive, we need to get them out of the car and move them quick. One second, I'll reply back to a student. If you are alone, use a drag to pull the patient along. Sorry, replying back here. So if you're alone, use a drag to pull the patient along the long axis of the body. So use techniques to help prevent aggravation of the patient's spinal injury. Like a closed drag, blanket drag, arm to arm drag. As long as you're pulling in that same motion going forward, or there it keeps the spine in line to your best ability. As you can see here, closed drag, blanket drags, under the arm drags, the different emergency moves that we can utilize. To remove an unconscious patient from a vehicle alone, move the patient's legs clear of the pedals, rotate the patient so the back is toward the open car door. You're going to place your arms through the armpits and support the head against your body. You're going to drag the patient from the seat to a safe location, as you can see here. Urgent moves are necessary to move the patient with altered level of consciousness, inadequate ventilation, shock, or extreme weather conditions. Rapid extrication techniques require a team of knowledgeable EMTs. If you ever were to take what they call a pre-hospital trauma life support or PHTLS program, which can be used for EMT to paramedic, it's more of your continuing ed, they teach you guys a lot about rapid extrication with severe trauma, like critical trauma patients. They should only be used if urgency exists. The patient can be moved within 1 minute. The techniques increase the risk of damage if the patient has a spinal injury, so try to look at all options before using an urgent move. But if the patient's going to die, or if they have a person still like some type of condition that may be like motor vehicle accidents with entrapment, patient's unconscious, we need to get them out. You can use an urgent move like that for that case. Non-urgent moves should be used when both the scene and the patient are stable, right? Stable vitals, we have time to waste to get out. Carefully plan how you're going to move the patient. The team leader should plan for the move. Look at how much personnel you have, any kind of obstacles identified, equipment, procedure, path. If you need to move furniture around in the house, move furniture around in the house, right? Make a path. You need to shovel outside for the snow, then shovel outside for the snow. Don't put yourselves in a situation where someone is going to get hurt. Let's see. All right. We want to choose between the direct ground lift. So for patients with no suspected spinal injury who are supine, patients who need to be carried over some distance, or EMTs stand side by side to lift and carry the patient. Again, we can do a lot of these moves on a practical day and show you guys exactly how these work. Extremity lifts for those patients who are no suspected spinal injury, who are supine or sitting. This works really well for patients who are elderly in a stair chair that really can't stand very well, or that lethargic that they can't stand. You can do your this type of carry or a move. But you need to coordinate the moves verbally. You have to go back and forth. You have your direct carry, which is a transfer move, which is moves a supine patient from bed to stretcher using a direct carry method. Or the draw sheet method is another one you can utilize by using your sheet underneath and sliding them over. Then obviously the scoop stretcher. So it is as it speaks. It scoops the patient up. So you can take it apart from side to side. Then you can clamp it back in underneath the patient so there's no rolling involved. I personally like using the scoop stretcher a lot. And when backboarding went away, I use the scoop for that all the time. So, all right, so geriatrics. Most patients transported by EMS are geriatric patients. Keep in mind that they have skeletal changes that may cause brittle bones, rigidity, and spinal curvatures that present special challenges, right? So if you're using a scoop, if you have to use a backboard of some sort, a reeve sleeve, apply padding to kind of help make the patient more comfortable when moving, right? And allay the patient's fears with a sympathetic and compassionate approach. as you can see, kyphosis and spondylosis, as you can see here. So if you have patients like this and you try to lay them flat in the backboard, it's not going to happen. So you may have to put pillows underneath and padding to make this patient a little more comfortable. Bariatric refers to management of obesity. 76 million U.S. adults are obese. 34% of adults are obese. Approximately 70% of the children. Back injuries occur for the largest number of missed days of work. Right? There are special stretchers and there are other methods to get patients that are bariatric out of homes. I will show you guys those methods for some of them on our practical days. But there are other special stretchers that are out there. There are wider stretchers so that they can fit. They have ramp and winch systems that go inside the ambulance that can be utilized as well.
Kevin,
Yeah.
is there a bariatrics type unit in our area that is just specific for bariatrics between Maine and New Hampshire?
So where I work, we have access to bariatric equipment. So Conway Village Fire Department has the Carroll County cache of bariatric equipment. They have the winch, the ramps, they have a hover jack system, everything there. Where I work, we also have a hover jack system to get bariatric patients out of homes, which I'll show you on one of our practical days because it's actually neat equipment to look at. But for the Shakopee area, I don't think Northeast Ambulance even has bariatric stuff anymore. I think they got rid of all their bariatric units. So if you have a very large patient, you're going to have to find the closest bariatric stuff. That might be Action Ambulance to get a hold of the equipment and bring it over to you in Shakopee. That's the only thing I know of in that area. Northeast used to have a bariatric truck with a winch and ramps, but I think they got rid of it years ago. So something to figure out for Shakopee Rescue is where's your closest bariatric unit, and if Northeast Ambulance does have one, or if United Ambulance has one that can bring one down to you. Remember, if this happens though, depending on anybody that's in this class, keep in mind that your bariatric units may be an hour and a half away, and you have to treat your patients on scene for an hour and a half before you transport. All right, so do the best you can with what you have for equipment, but don't put yourselves in a situation. Did that help you?
That did. I was just wondering because, yeah, because we're just seeing a lot of increased patients that are more obese due to health problems. So,
and another good thing also with dispatch is have them flag those houses. You know, so that way there you know that that when you dispatch to that home, it's a bariatric call, and you can start a bariatric unit faster if there is one, instead of waiting on scene to find out. So dispatch can flag anything you want for any home. So that way if you go there, it's kind of like LVADs for patients that have left ventricular assist devices. You can have dispatch centers put that in their notes so that when they get a 911 call for that residence, they can say, okay, the patient has an LVAD there, so just so you're aware.
very similar to like law enforcement, where they tag it for law enforcement before we arrive.
Yep. Yeah, because they've had prior history. Absolutely, they can do that. They can tell you the stage anytime they go to that residence, even if it's a medical call stage, because they may have a ton of firearms inside and they've been aggressive towards PD and EMS before. Yeah, so that's the best thing to know is know your area and have dispatch flag those houses to know that it's a bariatric patient. And they don't have to broadcast that over the radio. They can say, call in the dispatch for more information. They can just tell you over the phone. That way there, it's not so embarrassing, you know?
That might be something they would put in the CAD report too, when they send out the CAD through I am responding.
Yep, that they can do. They should be able to do that. They should be able to add notes, bariatric patient. So stretchers are equipped or being produced with higher capacities now, so which makes it nice. The problem is though, is it's not so much the capacity and the weight, it's the width of the stretcher and can the width fit on the fit. That's the biggest problem. There we go. So this right here is a bariatric stretcher. If you notice, it has the handles on front and back. That's designed to be pushed at the lowest level. So the way that's sitting right now, those handles are not designed for that type of pushing. It has to be on the very, very bottom. But it has a wider wheelbase for increased stability. The thing is that it's got to be able to fit inside of your ambulance. So the drawback we're seeing now with these stretchers is that the power load systems in your ambulance that people have now, this isn't going to work, right? The people that have the new system, the track systems now, this is not designed for a track system. It's designed for the old horn and pin. So some have a tow package with a winch, and these are rated to hold up to 900 pounds. The regular stretcher are rated usually for 650 maximum, but some of them are a little bit higher now, especially with the power load stuff as well. All right, so the pneumatic and electric powered wheel stretchers, as you can see here, make life a lot easier to move patients because there's really not a lot of lifting until you get to the ambulance. They're battery operated. The problem is what happens when the battery dies. It has a manual override, but the manual override can be kind of a pain. It adds way more weight to the stretcher for lifting, and to move the wheel carriage up and down, it takes a lot more force. The portable folding stretchers, I haven't seen these in a long time in EMS. So the bariatric stretchers, as far as the ones I have seen, are not battery operated. They're not powered. They're all manual. They may have some out there that are powered, but I'm sure they're a lot more expensive. A lot of services can't afford it, nor will they buy them, especially considering they may only get a couple bariatric patients a year. It's a hard justification to purchase that. So what New Hampshire did is every county, so the state got a grant, and every county, one department in that county has a cache of bariatric equipment now. So again, you don't see a lot of services that actually have this stuff anymore. So this right here is a portable folding stretcher. Again, not routinely seen in ambulances. Some models actually have wheels that can be folded in half, used to difficult to reach areas. Like I said, we usually don't see that. Less weight as well than wheel stretchers, but we just don't see them in the field anymore. These are flexible stretchers here that can be used for high and low angle rescue. Excellent for storage and carrying, and they can form around the patient's sides. Yes, very true. Military still uses those as well. Useful for confined spaces and uncomfortable, but provide immobilization and support. So again, easier to maneuver to get patients from high angle rescue stuff going up or whatnot. These are short backboards. This would be what they call a Kendrick extrication device or a KED vest type device. Most states have stopped using these, but they still carry them on the ambulance. Everything serves a purpose. I've used more of these lately on patients that have pelvic injuries, using it as a pelvic stabilization versus an actual use for a KED and spinal. Just because this is on the patient, you still have to hold C-spine. Nothing changes until they get onto the backboard. So KEDs are no longer tested on, and we don't really use them anymore. They kind of just sit in the ambulance. But I will show you guys how they do work, though. The vacuum mattress or alternative to backboards for mobilizing geriatric and pediatric patients, with air is removed from the device, allowing it to mold around the patient. Very interesting. I have not seen those around here at all. I do know they use those more out in the California and the West Coast, but they really haven't made it very popular on the East Coast at all. These are basket stretchers, otherwise known as a Stokes basket or a Stokes litter, used for removal at remote locations. They can use them for water rescue with flotation devices on them, or technical rope rescue and things like that, low angle, bringing them up over certain areas. They go really well over snow as well, so you can drag a patient over the snow with these. Do not tow them behind snowmobiles and four-wheelers. Very dangerous. But if you need to drag a patient by hand, it works pretty well. So if the patient has a spinal injury, secure the patient to the backboard and then place the backboard inside the basket. Lift the backboard out of the basket, please, and place it on the wheeled stretcher. Do not put the Stokes basket onto the stretcher and then transport with the Stokes basket. The hospitals hate it. It takes up a ton of room in the ambulance, and you can't really gain good access to the patient. So these are scoop stretchers, also called orthopedic stretchers as well. These things actually come apart at the hinges here. So you look at my mouse on the screen. That's a breaking point there, and the other one's over here. And there's tabs located here and here, and that allows you to take this section and make it taller or shorter, so you can make it to the height of the patient. So it splits in two. All right. So that's the scoop stretcher there. Now, there's no hooks on the scoop stretcher. Let me go back one slide here. Better. So you have to use what they call a 9-foot strap. There aren't pins inside of these. A hook on a quick connect clip. So you have to use 9-foot straps, and you have to strap these patients to these boards, right? And usually they don't come preloaded, so you have to have the 9-foot straps to be able to feed through. Neonate isolettes are a whole different world. Nothing that we are ever going to be transporting in the 911 setting. If you work for Boston Children's, if you work for the Barbara Bush through Northeast Ambulance, things that have the neonatal transports, then you'll have something called an isolette, which is sometimes called an incubator. Neonates cannot be transported on a wheeled stretcher. The isolettes keep the neonate warm. It protects the child from noise, draft, infection, and access handling. As far as decontamination goes, decontaminate all your equipment after every use. And we should all be familiar with that now, especially with COVID, but please make sure that you decontaminate and you wipe down everything. To answer your question, Nick, yes, we use it for spinal because we take them off the board anyway. So we can use C-spine, put that underneath the patient, scoop them, pick them up. That keeps the spine intact and straight. Put them onto the stretcher and take the scoop off, and they're back on the stretcher again. But the days of using backboards and leaving them strapped to the backboards now with head blocks is gone. They've actually removed that out of the protocols. So as far as positioning, depends on the chief complaint, right? So patients with head injury, shock, spinal injury, pregnancy, and obese patients need special lifting and moving techniques. They do. Especially the obese patients and how they're laying down or sitting up. They can have something called positional asphyxia, and they can actually suffocate based upon the heavy weight of their chest being down for so long. A patient reporting chest pain or respiratory distress should be placed in a position of comfort, typically Fowler or semi-Fowler position. That's sitting up or lying back just a little bit. Patients in shock should be placed supine, which is lying down flat. Lying down flat will help distribute the load of the body, therefore making it the workload a lot less. Patients in late stages of pregnancy should be positioned and transported on their left side, right? It can prevent supine hypotensive syndrome, where the baby is putting pressure on the vena cava, causing the blood pressure to drop. Yes, so Sean, that is correct. They are finding that backboards are actually causing more damage. They're also finding that spinal injuries are a lot less common than they thought they were. They did a lot of studies on that, finding that let's say 100 patients were, let's say 100,000 patients were transported on longboards because of suspected spinal injury. They found that like 2% of those patients actually had a spinal injury. So they realized it does actually more damage to put a patient on a hard board going down a bumpy road than a cushioned stretcher. Cervical collars, though, are still placed. We still have to place those. And we still have to hold C-spine when moving them. But that's it, though. A patient who is unresponsive with no suspected spinal injury should be placed in a recovery position on their side. Or there, if they happen to vomit, they can protect their airway. Patients who are nauseated or vomiting should be transported in a position of their comfort as long as they can maintain their own airway. Obese patients should be positioned the same with a similar condition. We're going to evaluate medical restraints, evaluate for correctable causes of combativeness. So again, hypoxia, hypoglycemia, head injury, and you need to follow local protocols. You need enough personnel as well to do medical restraints. You can't just start throwing restraints on people. Restrain the patient in a supine position. Positional asphyxia may develop in a prone position. We no longer sandwich patients between backboards anymore either. That was something we used to do like 20 years ago. Apparently they said that's a bad thing when you suffocate people in the back of an ambulance. So a lot has changed over the years with that. So we're going to apply restraints. As you can see, this patient actually is on a backboard with a spider strap system, which is actually pretty interesting. I have some of those. Nice, nice. So apply a restraint to each extremity, one arm up, one arm down, usually is the best method. Assess ABC's mental status, distal circulation after restraints are applied. Make sure they're actually getting oxygenated and you're not losing any circulation. And you have to document all information on what you're doing. Personal considerations, questions to ask before moving a patient. 1, am I physically strong enough to lift or move this patient? If not, find some help. Is there adequate room to get the proper stance to do the lift? If not, I need to slide them on the floor until we find the right spot. Do I need more help? Injured EMTs cannot help anybody. If you hurt yourself on scene, now it's another patient. All right. So what is the first rule of lifting? A, B, C, or D?
B.
D it is. All right. Number 2, when lifting a stretcher using a power lift, you should do what?
A.
Isn't it C?
I'm saying A's, C's, kind of a mixture between both. So the answer is C. When lifting a heavy object, your hands should be facing palms up. This provides better lifting power and is not as stressful on the wrists. It is impractical to apply a vest-type extrication device on a critically injured patient to remove him or her from a wrecked vehicle because that's that KED device I told you about, the green one.
I believe it's B.
So
Yeah, I'm gonna go with.
right. So remember that critically injured patients need to be, it's A. It takes several minutes to correctly apply this vest-type extrication device. So again, I'm going to show you guys how to properly put it on. And it takes a lot of time and movement and everything else to properly put on a KED. That's why we don't use it anymore. It's just, it takes too much time. but I will show you guys how they work because it is a National Registry skill. You will not be tested on it though at the New Hampshire testing site, but it's still a national skill you should be familiar with. Number 4, proper guidelines for correct reaching include all the following except.
D.
All right. See a lot of D's. D, avoid reaching 30 inches. We only want to go as far as 15 to 20. Number 5, an injured hand glider is trapped at the top of a large mountain, must be evacuated to the ground. The terrain is very rough and uneven. Which of the following devices would be the safest and most appropriate to use?
B.
Don't
A.
say a don't say a helicopter. Yes.
Life
So
flight.
what was that?
Life flight.
I wish they did lifts from a mountain. That would make life so much easier. They don't have that ability unless they have a big enough spot to land. But yeah, Stokes basket stretcher. When 2 EMTs are lifting a patient on a long backboard, they should.
D.
D.
Perfect. D it is. Number 7. Which of the following techniques is considered to be an emergency move?
D.
C, firefighter drag. The one-person technique that can drag the patient from a life-threatening situation. So number 8, you extract a patient from the basement of a building. You must transport the patient up a flight of stairs. In doing this, you must ensure that
It's A. Elevating.
yeah, a lot of A's. You always want to make sure the head of the backboard goes up first. Over there, it's easier to help prevent from vomiting and also protects the airway better. All right, number 9, if an injured patient needs to be moved but is not in immediate danger from fire or building collapse, you should do what?
E.
So I like your thought process would be check the patient's airway, breathing, and circulation.
I was gonna say D.
Oh, D. Someone said B. Hard to tell the difference over the speaker. Sorry. Yeah, so they actually said B on this. So again, to kind of go back to that, if I can hit the right button here, it'd be better. If an injured patient needs to be moved but not immediate danger from fire or life, right? People would think the answer would be D, right? Determine the number of people you'll need. This is a typical National Registry question. What would you do first? Airway, breathing, circulation, every time. They're trying to trick you to think outside of it, but there's nothing in there that says the patient's stable or not. So you don't know until you figure that out. They didn't say unstable patient, they just said immediate danger. So they want you to check ABCs before you make the determination how you're going to move a patient. Those are the trick questions they're going to put into your National Registry exam. So number 10, the rapid extrication technique is a
D.
yeah, so technique used to quickly remove a patient from a vehicle. All right, let me turn the recording off really quick.